Welcome to the Bethune Roundtable 2021. Today we're going to talk about laparoscopic surgeries in rural areas. Why are we doing that? Laparoscopic surgeries is one of the landmark innovations that dramatically change the way we perform surgeries. The first one, in fact, was discovery of anesthesia, then the asepsis. And although this is as significant as those two innovations, the penetration of laparoscopy surgery is not great because even now only about 10% of the world carry out laparoscopic surgeries. Before we go into the details, we'll have a short look at the Association of Rural Surgeons of India and International Federation of Rural Surgeons. Have a look at the 2-minute video before we proceed. The Association of Rural Surgeons of India is a group of brilliant surgeons who work among the rural areas, serving the poor and the marginalized. There were many innovations that were made by the rural surgeons to serve the poor and the marginalized. And one of them, the use of mosquito net for tension-free hernia repair, is listed as one of the 6 famous and effective low-cost innovations for surgery by the World Health Organization. The World Health Organization also included the gas insufflationless laparoscopic surgical equipment as part of the WHO compendium of innovative medical devices for resource-poor settings. The gasless laparoscopic surgeries, or GILLS in short, was developed to meet the needs of the patients in rural and remote areas. It makes laparoscopic surgeries possible under spinal anesthesia at a very low cost. The association was instrumental in starting DNB course in rural surgery and to get it recognized by the Medical Council of India. They also offer fellowship in rural surgery. Recently, they started a variety of certificate-level courses with the innovative online on-site training format. The annual conference of the association attracted many overseas delegates, and this resulted in formation of the International Federation of Rural Surgeons. These are 2 YouTube channels where training videos are posted for the rural surgeons and also patient education videos for the rural patients. The association also arranges workshops to teach innovative gasless surgical techniques and other low-cost innovations like the just external fixator system or rural urology using the laptop cystoscope. All you need to do is to connect the scope to the laptop computer and start doing these diagnostic scopies or minor procedures.
Thanks to the impact and success of the model in empowering the rural surgeons, many who are interested in global surgeries have pitched in to help.
Coming back to laparoscopic surgeries, why is laparoscopic surgeries important? They cause less infection. There is less post-operative pain. The hospital stay is short. And there is much better utilization of the limited resources in rural areas. This makes them very, very relevant for rural areas. But then, as you mentioned earlier, the penetration is not good because of several reasons. One of the most important reasons is that we need general anesthesia for laparoscopic surgeries. And the logistics of providing gases for anesthesia and for surgery is very, very difficult in rural areas. And then there is a very high investment which is necessary for laparoscopic surgeries. Added to that is the cost of disposables. But of course, this didn't prevent the rural surgeons from trying out laparoscopic surgeries. When we started, we used the cystoscope to carry out laparoscopic surgeries. In fact, we used the BP cuff for insufflation. And we started with the small procedures like diagnostic laparoscopies. And then we carried out appendicectomies with a small incision over the McBurney's point. And then when we became proficient, we wanted to do laparoscopic surgeries in rural areas. But the main problem, as I said, was we have no anesthesiologist. And most of the time it was the nurse anesthetists were using, as you can see here, EMO and ether for anesthesia, which is much, much less expensive. Again, the equipment, if you look at the cautery machine, it's a World War II cautery machine. But then we made modifications, like we used a dental compressor for insufflation. The first 5,000 laparoscopy surgeries we carried out with the ether and the EMO machine. And then we started reusing the disposables. In fact, the very first disposable port, we used it for more than 500 times. Then we changed the techniques. In fact, we started doing many laparoscopy assisted procedures that gave the advantage of laparoscopic surgeries without the associated costs. And this is the context in which gasless laparoscopic surgeries became very relevant. Dr. Hashimoto is father of gasless laparoscopy surgeries, and he never did it for the cost sake. And of course, the early instruments he used were very complex and difficult. Initially, they were all carried out for the sake of physiological advantages that isobaric system offers, especially if the patient is a compromised patient and the surgery is prolonged or very long. But then the early devices had a problem associated with tenting or poor exposure. Even the mechanized devices did not make much of a difference to At the same time, in India, people started using gasless surgeries because of the fact that anesthesia. And then there came many advances and modifications with complex instruments, but which none of them actually significantly improved the exposure. The first device which sort of gave an exposure was similar to the conventional laparoscopy surgery, the abdominal lift device by Dr. Daniel Kruszinski. There were modifications of this in the second generation equipment and so on. And we got this device made, which gave us almost as good an exposure, especially the BMI less than 28. And it is very easy to use in remote areas. So what did this do to us? We did more than 1,500 surgeries where it may not otherwise be possible to do these surgeries. Also, there are many rural surgeons who would otherwise never done laparoscopic surgery who started doing these laparoscopic surgeries. This increased care in rural areas. So why do we need gasless surgeries? The most important significant reason that we use is that surgeries are possible under spinal anesthesia, including surgeries like cholecystectomies. And then it can be used even under no power supply, no gases, and so on. And what we really like is that the learning curve is not as steep as for conventional laparoscopic surgeries, and traditional open instruments can be used for it. Now we'll have Noel talk to you about how we developed a training program and what are the various studies that we did to make sure that these procedures are not inferior to conventional laparoscopic surgeries. Thank you.
Dear Bethune Roundtable, thank you for this opportunity to speak today on innovation in laparoscopic surgery for rural India. Following this fantastic talk by Dr. Ganraj, I'll be talking about the diffusion processes of innovation in rural settings. I share my experience on training rural surgeons in gasless laparoscopic technique in the rural Northeast India, and finally discuss some points on implementation of new surgical technologies in global surgery. So what are the challenges when it comes to diffusion of innovation? According to this conceptual theory by Professor Rogers, who was a communication theorist and sociologist, explains that diffusion process itself is a social process. And over the time, let's say the gasless laparoscopy technique, it requires enough evidence to reach to this tipping point, which is the point of adoption where almost 20% of the adoption of this technology has started taking place by early adopters. And following this, as we communicate the importance of this technology to the relevant groups of people. More people are interested in this technology, and the S curve, as you can see, starts to go up, and the adoption process of the technology starts increasing over the time period. However, it's not that simple because we also need to understand the dynamics of the diffusion. And as explained in this article by Professor Wilson, apart from the technology, we need to understand, does actually the patient need this technology? What about the cost of learning for those who are going to implement this technology in their settings? The supply chain, manufacturing, is it beneficial for the manufacturer? How can we convince the stakeholders who are going to use this technology in the regional level or the national level? And also the cost of use of this technology in the setting. Are the managers of the hospitals convinced that this is a cost-effective technique for their hospital, for their patients in the region? So I've been part of this surgical technologies group, as you can see, an interdisciplinary group of researchers who collaborated with the Associations of Rural Surgeons of India and the Maulana Azad Medical College in Delhi. We've talked about the gasless laparoscopy in the previous lecture, and most of our project was based around this technique of performing laparoscopic surgeries in rural settings. But before that, I wanted to talk about this paper that was published in November 2020 by Maulana Azad Medical College, which compares gasless cholecystectomy and appendicectomy with conventional laparoscopy. And as you can see, there was no difference in the operative time. And actually, the intraoperative vital signs were much better for those who had gasless laparoscopy technique. The pain scores were slightly higher for the gasless technique. However, the patients did not require excess amount of painkillers to control their pain. Other outcomes like conversion rate or complication rates, there was no difference. So the study says that there is a potential for gasless laparoscopy to be used in rural settings, and it's a non-inferior option to that of conventional laparoscopy. So our research was focused in the rural Northeast India, a population of 45 million people who lack access to surgical care, primarily because of the health system and the geography of this region. According to the Disease Control Priorities 3 document published in 2015, 1.5 million deaths could be averted if essential surgical procedures are provided. And many of these procedures are acute abdominal conditions that can save 9% of the deaths globally. For rural Northeast India, we feel that the overall surgical need from the data that we analyze is 5,500, 400,000 population. And many of the surgical procedures in the region are amenable for laparoscopy, and patients can benefit quality of surgical care. We map most of our projects to that of the Lancet Global Surgery Indicators. And today I'm going to talk about the target study, which focuses on the specialist workforce density and surgical volume. The target study was an objective feasibility study which objectively evaluated and trained rural surgeons, 7 rural surgeons of Northeast India in laparoscopic surgery using the gasless technique. We used the FLS scoring system to train them on laparoscopic simulators. And as you can see, before training and after training, there was an improvement in the MISTEL score. Operative skills were assessed using the OSAT score, which assesses the operative technique, and laparoscopic skills using the GOLD score. And finally, the costs of the training program, and as you can see, as demonstrated here. So we feel that it is feasible to conduct these training programs for rural surgeons in gasless laparoscopy technique in the context that we were working in, and potentially has benefits if a larger cohort of rural surgeons are involved in the training, but further studies are required to ensure the benefits of it. These are the 5 tasks that they were trained on, which assesses different laparoscopic skills on depth perception, bimanual dexterity, their laparoscopic suturing skills. And over here, you can see them in action here, trained by a group of Indian surgeons who are interested in rural surgery. And over here, the line graph describing the improvement in their scores for all those 5 tasks on the left side, pre-training and post-training. And on the right side, you can see the progression of their improvement in the laparoscopic skills, the overall scores. 2 months later, we went to the rural hospitals and trained them in the gasless laparoscopy technique on their patients. And it was phenomenal to see the rural surgeons being able to use this technique for their patients and bringing benefits to the community. 2 years down the line, we know that the rural surgeons are now performing these procedures independently, and the number of cases that they perform has increased 3-folds. Here you can see some of the pictures of them performing these procedures independently in their hospitals. Finally, our group has embarked on this process of improving the design of the gasless lift device. On the left, you can see the old device, and now the new device called the RAISE device that has been evaluated for the past 2 years. The overall procedure was a collaborative process where we agreed with our partners in India that an improvement of the design would be of benefit to the end user. A truly collaborative process working with the rural surgeons, industry partners, designers. We conducted cadaveric studies in India, as well as in 2020. Although we were faced by the pandemic, we continued the evaluation virtually and involved our team from India. And this is the final product, which is still going final evaluation before the surgeons are able to use that in their rural settings. So just coming to the end of my slides, I want to highlight that health technology is not just about the clinical aspects, but also the social, ethical, and holistic approach in understanding the value of health technology and impacts of health technology regionally or nationally. The World Health Organization talks about the systematic approach called the health technology assessment, which evaluates this impact and informs the policy decision making with the funds that are available for this health technology assessment. And I think as a global surgery community, we need to understand that the implementation of innovation, the patient is at the center of the innovation, and the process of it is carried out ethically. It has a sustainable element to it, a collaborative fashion in how the evaluation is taking place. And the innovation itself is frugal, that it can do more with less. Thank you very much for listening. I look out for any questions that you have. See you.